next speaker is Dr. Jayanthi Parthasarathy, Department of Radiology, Nationwide Children's Hospital, Columbus, Ohio, from United States. I am very happy to introduce her. The previous speaker, in his speech, he questioned about the physician turned future biomedical engineer. Actually, she is the person who was the surgeon turned additive manufacturing specialist. He is a specialist in 3D printing, etc. Dr. Jayanthi Parthasarathy is a trained dental surgeon having practiced dentistry in India for more than 3 decades, transgressed to additive manufacturing for clinical needs after completing masters in mechanical and manufacturing engineering from College of Engineering, Guindy, Anna University, and she pursued Ph.D. at the University of Oklahoma, USA. She has been at the cutting edge of 3D biomodeling and 3D printing to arrive at patient-specific solutions for complex surgical challenges in the adult and the pediatric population for more than 2 decades, in specializing in development of patient-specific devices using advanced design and manufacturing technologies as 3D printing with in-depth knowledge and experience in navigating FDA approvals for medical devices. She has won a lot of awards and honors. I'll just name a few. 3D printing, dental and medical pioneer of the year 2020. Outstanding PhD dissertation award in 2009-10. School of Industrial Engineering, University of Oklahoma. Design, analysis and fabrication of porous titanium implants using electron beam filtering for craniofacial applications. In 2008, Dick Aubin Distinguished Paper Award SME Rapid Conference and Exposition 2008. Founder President Award of the Indian Society for Dental Research 2001. Fellow of the Indian Society for Dental Research 1999. Captain Dr. J.J.S. Gangadharan Memorial Award in Orthodontics 1998. Jawaharlal Nehru Memorial Fund Award for Meritorious Students, Madras University 1973. We are all very fortunate to have such a very eminent speaker before us. On behalf of the RMK management and on behalf of all of you, hearty welcome to that for us. Wonderful. Thank you.
Thank you, sir. It's really great to have you here, ma'am. As a token of our love and appreciation, may I now request Dr. Jayanthi, Principal R&D Engineering College, to honor our resource person, Dr. Jayanthi Parthasarathy, Department of Radiology, Nationwide Children's Hospital, United States, the shawl and momentum. Thank you, ma'am. Thank you, sir.
Good afternoon, everyone, and I really appreciate the opportunity to be with such an august audience. And I'm very humbled with the great elaborate introduction which Professor gave us. And thank you very much. I really appreciate it. Come on. We'll be hearing a little different talk about digitalization. I've always been very interested in digital transformation of images. I don't think a lot of people are talking about big data, the patient health recovery. But for the past close to over 35 years, since 87, I've been looking at transforming images. Like first it was X-ray for about 10 years from 87 to 97. And it was a time when I came back from UK after my training in orthodontics. I went to the CAD center and said, teach me AutoCAD. The person said, no, you're a doctor, you cannot learn. And give me a problem and solve. I said, I'm a doctor, I'm going to see different problems every day. And every day I'm not going to be at your doorstep asking you to teach me. Then I decided, okay, there's one thing I tell your students, there's nothing what you can not learn. You have your mindset and you'll definitely be there. And the man above God will send you the right person to guide you at the right time. That has been my life experience in every walk of my life, whether it's my profession or my personal life. So then I'm trying to get AutoCAD 2.0 and I tried to get a computer from HCL. HCL took me 1 whole month to discuss what is the configuration of the computer that I was going to get. And those days, believe me, I paid 1.5 lakhs to get that computer. In 87, it was a lot of money and it carried a lot of value. And you could get so many things like that. But they did a very good job. And those were the days when you buy a computer, they will give you training for a week to use how to use a computer. One day would be DOS operating system, one day they'll teach you Word, one day they teach you PowerPoint, another day they teach you like Excel and spreadsheet, and people will start using them. I started using the computer that way, but then I started learning AutoCAD. I had a friend of mine who just then got introduced to me and we started writing programs together. And as things should have it, he moved to UK in 6 months after working with me. Then I was left as a fish in the pool, trying to swim and making my own programs for all my needs. Then in 97, I went to see Dr. Chandrasekhar when he was at AFRD Center for CAD-CAM. And he said, ma'am, you've done 2D for 10 years, now it's time for you to move to 3D. I said, what do you mean? But I had already seen these stereoscopic models, rapid prototype models in 95 at a conference in Berlin, and I was really amazed how did they even get here. Then the next day I went to see the AFRG was getting their FDR printer that the next day it was being installed. I went to see them, I saw them printing a manual. I was a surgeon at Mullen Hospital, and when I said, okay, here is a solution for my patients. Because I used to dissect a part of the jaw with the tumor. When I saw a mandible on the lower jaw being printed, it took me to a knife job. I said, here is the solution I have for my patients. So I started adopting that in 97, 98. And those were not the days of digital X-ray. We used to have those sheets of the CT scans. Then myself and another professor at AFRD, Mr. Gunasekar, we used to scan those X-rays for those CT scans, do noise reduction program. We did everything down here to get a CT model. Then, and I started speaking a lot. In 2003, I decided this is the technology I need to adopt and go more into it. And Anna University, Professor Gauri, the current Vice Chancellor of Madras University, was very kind enough when I asked him, sir, I need to do a program here. He said, Dr. Parthasarathy, but I can't take you for a PhD because you don't have an engineering bachelor. I said, sir, I just want to learn the technology. I just want to see how deep I can go into it. He was very graceful. 2 weeks later, I get a letter saying, take this entrance exam. I'm like, where do I go and write an entrance exam with all of the engineering lecturers and pass out and come and join. But as I said, God was there with me, gave me that opportunity to join. I was probably the first entrant to do a master's, a doctor without an engineering degree, to do a master's in engineering. I'm very thankful to all these people who have walked around with me and brought me to where I am to justify for me to come and talk in front of such august big engineers who teach engineering to talking of students. I'm very, very thankful for the opportunity. And I thank our organization and all of you for having me. I just kept you engaged until my presentation was getting ready, trying to tell you a little story, which could put a little thought in some of your minds to say that that's the way you come out of college. You come out of college, you think the whole sky is under your thumb. But it will be under your thumb. If you really have the intention to, you can get where you want to go.
My daughter did.
This very clearly shows that we have the best of minds here who can help us in terms of crisis. Without this PowerPoint presentation, I wouldn't have been able to show you anything. Okay, let's get started. And my topic for today is going to be uh, apologies for the main start. Let's get started. The topic for today is going to be 3D biomodeling and visualization. We all go into the surgery. Anybody who goes to surgery, it's only real. Not only the patient. I can tell you. So, what family is really scared of when the person goes into the room, then the doctor and the rest of the you can hear, right? How can you hear me? Can you hear me? Okay, stop. Thank you so much. My topic for today is going to be 3D biomodeling, 3D visualization. As we said, we have the very modern separation talks are discussed situations, but the research is not see what is going to see. Certain aspects that into the environment. To be I have nothing to disclose. Butterfly is our logo, so we all fly. Today's learning objectives is going to learn to understand a little bit of what we expect from Society 5.0, and we're gonna, this is going to be a 30,000 foot overview. It's not going to get you into detail, but it takes you to walk through to what system of the iPhone. Then you're going to integrate technology, and you will all come in to help us with developing the program. And we're going to understand what sterilization is technology will and what is going to move you. And just let's define certain personal medicine. We want to talk about personalized medicine. What is personalized medicine? It's basically using patients' unique data, whether it's images or it's going to be their healthcare data or their personal data. We are going to derive a treatment plan or select that data and analyze. Innovation is what we are looking out for next generation. Give us under the guidance of our current professors and outcome is the result of the treatment. This concept, awareness, and it can be in various ways. It can be elimination of the disease. In certain times, it is just a reconstruction of destroyed energy. Say, somebody has a tumor. If you remove that tumor, it can remove the tumor. So, reconstruction is lost. Somebody has lost a part of the leg. Reconstructing it. Making walking. This is the one message of the how fast you can walk, how fast you can walk, how much less pain you get, all that will be a message. And let's take a form and function which are being talking here in the engineering world. Innovation has not the performance has also to the function. Human body notice. The hospital stay. Every day a patient in the hospital costs a lot of money. So we want to keep the hospital stay cost of money. So in the US, you say, for no surgery, patients get the hospital for more than 5 days. Once it goes more than 5 days, the cost can be longer. Even a cardiac surgery, the 4th stage they are discharged. If they have open heart surgery, 4th stage, 5th stage they go. They have a second section, next stage they go. So they keep the hospital very minimum. Then we have the work skill, the cost factor. Time to get back to the mean. A person is working and if he has a surgery and he is going to be away from work for about the whole month, you have so much loss of productivity, which is the benefit. Then the anxiety starts with the family and patient satisfaction. Some of these metrics will take into analyze the outcome of it. When you look at patient trials, there are 4 clear parts. One is personalized treatment. The doctor predicts to see how the treatment is going to work with the patient. Then he's also going to talk to you about preventive treatment. If the diagnosis as a diabetic, he's going to say, don't take sugar, don't take oil, don't do that, all these are preventive. Then you expect the patient to participate in the treatment that you're going to do. Because only a compliant patient can become more healthy. So how this 3D biomodeling and computing is going to help us in that work. There is a paradigm shift in to get better outcome. Now the radiologist or the person who takes the physician who reads your X-ray, CT scans, MRI. He is the enabler. He is the person who helps the surgeon to visualize or see what is needed. The enabled is the surgeon and the patient is also enabled. So the patient gives an informed consent. Before the patient goes into the procedure, he understands what is going to happen to it and what is expected out of it is what is needed. So you have a better patient compliance, better outcome. Radiologists and the surgeons in different ways. Radiologist is trained to convert 2D images in his mind into a 3D volume. But whereas the surgeon is not. The surgeon sees what he opens up. He sees the person physically. So he doesn't know how it looks like on the 2D. So the same problem, 2 different people look at it from different perspectives. Begin radiologist tells the story from imaging. Is Padam Kadeshwari. the surgeon is, he's very hands-on. He's ready with the knife and his scalpel. And he just cut the patient and see what's inside. The decision making support, you have the CT, MRI, you have ultrasound, then you have other images, you have the 3D model. Problem statement is, as we said, the surgeon sees anatomy in 3D, and so he doesn't know much about before he goes into the surgery. He doesn't understand so much of what he likes from this. As a surgeon, I've written that place where I really know what my surgeons are looking out for, but they really don't have the opportunity. And then this leads to making decisions on the fly. In the OR, when you're operating, you have to make your decision. It has to be quick, it has to be the right decision, and because you cannot go back on it. Because if the decision does not go to the patient's problem, you have to take the patient back into the operation theater and do second surgery, which is not sure. And increase surgical time or your surgical time will go from 2 hours to 6 hours, which is again not good. And these are today I call what's called Googlacharya. So you have a question, you say, hey Google, give me the answer, and there you are. But the surgeon doesn't have the start. You cannot go on to surgery.com and say, what should I do here? Probably we might have, as we look into big data in the next 20 years, 30 years, the outcomes of all of that might be able to have to answer. And all this leads to suboptimal surgical outcomes, which you want to do. Solution is patient-specific enhanced visualization. Make them see as much as they can so that they understand the difficulty more. They understand what the underlying problem before they get into the surgery. But dealing with life and human beings as a surgeon. Okay. The enabling technologies, you're all very familiar with. There's no CT or MRI without the engineering world. There is no advanced image processing or segmentation, as we call, without any of the software programmers. And today AI is taking up a lot of it. So we're getting into more of automated segmentation, and then the 3D biomodeling, where within a few seconds you're able to get these models. These models can be put into augmented reality or virtual reality, where I'll show you a video later how two people can collaborate with them. And they can also be got into 3D printing. I saw your ideas lab, which is going to be inaugurated tomorrow. So yesterday, and it was just so nice to see the 3D printers and the scanners, which is all going to be. And that's when I told that we should have a strong healthcare connection. The press of a button does not give you a 3D model in the medical world. It starts from just like your 2D drafting, and then you take a 3D model. Here, our input comes from the CT scan, the MRI. You create a 3D virtual model. And from the virtual model, there are certain things which you might have to add for structural stability and do all that. Get the approval from the physician before you go ahead and print it. You have a printing system, post-processing, and then you deliver to the physician. All this means that you're going to add errors in each of these procedures, so that cumulative errors cannot be beyond assessment. So a very good quality system is very essential so you can get the right model. Virtual to physical transformation, where you have a virtual model, you have the thinking process happening, and then as the full job is completed, you have the external support to solve that. Now you put all those together by means of magnet. So the surgeon sees the whole thing, all he can split it and now he can measure from his access point. The pink part is actually the tumor. So he can decide his access point and see how far he has to go. All specialties of medicine can are using the modeling. What can you do with this? You can do anatomical models, you can do virtual physical planning. You can do the surgery on the computer and then decide which is the optimal treatment plan. You can plan your surgical guide so that just like the treat once you open up, you can put the guides on the patient and then do the cuts and then finish up your surgery. Implantable devices, patient devices are very effective. We've done a lot of them for the past 15 years. There is, now we see what is the specialty what uses. There is a congenital heart defect. As I will tell you, the two blood vessels are interlinked. Each one should be in one chamber, but they're all in the same chamber. It's a very complex situation for the surgeon. And so, and there's also a hole in the heart, which is got to during this surgery. This is as you can see in this slide, there's an extension. So now you're going to see this extension. You've got to do the right sizing. This is another surgical planning where they wanted to do not an open surgery. They're going to do an intervention surgery. But once we made the model, we were able to understand that it's not possible for them to do an intervention. The person has to go for an open. Another very difficult situation. This kid is hardly 5 days old. So you can see how small the building suits are going to be. So where there is difficulty in such little the structure also is also small. The pediatric world, another challenge is these kids are growing. So the size changes. And it's a very small market. So the big players do not want to come here and spend their time on money. So a lot of times, one of the this is a human brain where you see the neural tract and parts of the tumor. So brown spots are the magnets. Then you see this is a nerve tract. So when he is attending at this tumor, if he hits this nerve tract, he is going to injure either the vision or the movement of the person. So these ones, you build them one to one, and over here you've seen the accuracy to be at less than 0.1 millimeters. So I think I will do that. There is all these situations. They can never see before the surgery. They cannot see where the teeth are going to grow in the sun. And then I grow the thousand of they can't see. So during that surgery is very important. There is a tumor which is affecting the brain, the nose, and the mouth. So there are three teams of surgeons. There's going to be a plastic surgeon, a neurosurgeon, and a pediatrician who is going to operate at the same time. The kid is 3 years old, and so they need to understand, right? Each one is going to who's going to start first, what's going to be very useful. Trauma reconstruction, this person had a gunshot and the mind was all these little pieces were strewn all over the doors. What we can do in a virtual surgeon, pick up each of those pieces, put it together, see how nicely from here to here we have reconstructed. Now we can make this, take the 3D model and we can actually bend that tree before they go into the surgery. So that can be used as a template for fixing. And you can give a different color for each of those segment parts. Identity. This is a destroyed lung. You can see the extent of this. It's again a very complex surgery where they do a very minimally invasive surgery, just the 3 millimeter keyhole. This is actually, there is they usually track the speaker track and the users. Everything has one common one, which is very complex and they have to operate the patient. And most of them also have spinal defect, so they cannot study how it. Once they have this model, they have something in happen before they go into. Here is a top foot where you can see that there are a lot of missing bones. So now this model, we build this with these studs will have the flexible material. This will be hard material just like bone. So they can actually move each of those joints and see how they need to reconstruct. It's very disheartening to see a spine uses like this. This is not a 2D curve, it's a 3D curve. Goes in all kinds of directions. This is the all from the head end to the foot end is so hard. So how are they going to make these children right? How can they even see how these? This was a very interesting thing. This is not patient specific, but it is how the family education is there. There was a blind, a visually challenged couple. Both the mother and father could not see anything beyond the shadow. They were going to have a child with a very complex health problem. And that child will need surgery the day of the birth. So how are we going to explain to them? The family said that your child is having a story. So they came and asked me to do something. I said, okay, let's use the brain. And people are very good at brain. So we created these models. Here you can see this is a normal heart. So you can see that the two chambers are nice and white, raggy. Here you see this is very small. But this is small. So we gave different textures each of this, and we made the heart structure as soft. So they could pass their hands on and see what geometry we were talking about and what was the problem. And they were so grateful. The child had 4 surgeries within the first 6 months of life, and for every surgery we made this, and they were so happy. So the first thing we did was thank the English. We were able to translate all this in grade and ask them to part and did it. It really made a lot of difference in their life and their time. This is a unique opportunity which I had. We had a conjoined these kids are joined all the way from the step to the present position. You can see they had two different hearts, but this particular child disease one liver. So the doctors had to split the liver, and the pelvis was also split. So they had to do a very complex surgery. So they took about 32 hours. Otherwise, it would have taken 48 hours. With the model and about 6 months of planning, the surgery took 32 hours. And we had, I think, about 38 people on the team who were operating at different times. If you want more details on that, they are called the Mata twins, MATA Mata twins. And you see that they are operating at Texas Children's Hospital. And now you can see how happy the kids are separate. Remember, the parents are happy. Okay, whereas one, then from the CT and MR, we built this model. This is our digital model. We took the CT scan and the magnetic resonance scan. We built it in such a way that we cut the whole thing and they would separate each one. So exactly the way they ought to be separated. So we gave them a guideline. So and we also put the liver as it could be picked up when they wanted. They wanted to see the structures behind. They would be able to separate the liver. And we found an avascular region, that is avascular region where there was least blood supply, where they could cut the liver and split it and have a joke. Now these kids are in elementary school and they are so proud to see them. And I happen to be the 3D modeling and 3D. So they are very unique and great opportunity. Now we go to virtual surgical planning, how you can do the surgical planning, and you can do for all kinds of brain tumors, dental implants, a lot of people use. Orthopedic tumors. We recently got a paper on that. Here is a liver tumor. So the surgeon needs to cut this part and take this tumor out. And how these blood vessels are going to be placed, give them a 3D virtual model, which they can move, rotate, and see. They can switch on and off any of the parts, and then they can see exactly how they need to do. There is they're going to do what's called a they're going to just like to have the gap. We use these, they're called distractors. This trajectory is very important to see how you can move these particular things. Because the surgeon came to us saying that I'm going to take 10 millimeters of this bone, identify the right spot. Right? I'm going to reconstruct the right. But when we actually did the virtual surgical class, he told him that 10 millimeters was into the 21 millimeters of whole body. We found an appropriate place for him to do the cut. Very happy because otherwise he had cut only 10 millimeters. It wouldn't have been enough for him to recut. Then you need to go more. This is again where you see this is a bone from the leg is being reconstructed for the jaw. So you can see the complex shape of the lower jaw and a straight bone. Now we are going to cut. So what is the angle that? And this also has to serve as a component for the upper, where you put the teeth and the patient. So it's very complex and so these guides work very well in that being established. Here you see this is a huge big colored tumor, and there's no way in which they can see how much it is. Any of the other systems. So they have a physical model, they're able to see, I'm going to cut the bone here and have some gland of it. But this is a one-to-one picture. So you can see how, so this is a part of the defect. This was the defect in the plant. What is the exact? Methods are very happy to work. This guy prevented, reduced 2 brain operations to 1. So we made the guide and this is being done in one go. So we're able to open the skull, put the guide, do the dissection, and then it implants back. But otherwise, normally, first stage, you do the tumor dissection. After 3 weeks, you do another brain surgery. Avoid one brain surgery. Running. So, my colleague, you can see how he's putting a stem. But the other two are the cardiologists. This is the person who's going to do these surgeries. So, how interactive it is, how they can understand each other. It's a very powerful thing. So they're able to compare two patients at the same time, having the same problem but different. But simulation is another very important thing for treatment planning, where I also work on clinical properties to equate to that of patient. Yes, you can see this is a blood vessel called the pulmonary artery. This is connected to the flow pump, and your CRT is the same. So you can see the flow. This we can simulate the patient as pressure and other things. This is another, this is the plant of stem. These are heart stem. So you can also do some clinical trials with patients such as one to get the right result. So we use these bonds for teaching. So we make all these bonds with exactly the. Okay, you can see these are my below. But trying to understand the heart. Oh, yeah. Okay. Sorry. Okay. This is a lung surgery where they have to remove a part of the lung. So and this is also minimally invasive. So they're going to remove a part of the lung with just 2 millimeters of the critical weight. So we use this for fellows and skin like silk and sit on top. Now you can see how skin properties and material composition becomes very. Here is my ENT service. It's holding one of the body time in a stem year. In the US, you say it's about 85% of the children have ear infection. Not sure whether it's better or worse. A lot of them need the skin. Possibly colleague which we do. What's the advantage? We have the physical model that have to touch the constant. We're also used to touching. Talk about the digital world, but there is a different feeling. And so then patient education and better compliance, we already saw that, and surgical rehearsal and team for good cost efficiency. Reduce operating time, predictable outcome, reduce the process, no symptom. So now, I don't have to talk a lot about it, but where are all of them? Use of polytech machine where we can combine principal and end products which have mechanical properties. We bring that up from here. We can do contact colors, contact colors, this is a very fine blood Firewater and fire. Not really talking about it. These implants were made. This was made in 2008. This is absolutely fine. Every time I come, I talk to him, and I started making this scalar implants from titanium mesh in 2005, and now it's most of the 1980 years, they're all doing fine. This is a 3D printed, and this is one of the parts from my Ph.D. research where I work on ladder structure, mechanical parts. So, 3D printing lends itself very comfortably to engineer mechanical parts. So, this is another publication where we did from the geometry factors of the parts. Titanium plant. Here we have PCR, augmented reality, we see the on and how we read it. All kinds of change those structures. Very powerful, very powerful. And I have my radiologist sitting in one corner of the hospital and I have my cardiologist sitting in another corner. Both of them together are collaborating and talking. And the conference is happening in an auditorium in church. So you can see one of the radiologists applications and how they do it. It gives a lot of interaction between people and between the physicians and what makes a successful program. We all spoke about PQM. Protocol very, very important. As you know, there are so many steps into it. Start to right transmission selection. Your image data must be right. Your program must be the first one. The person who is doing the segmentation must be believe me, the surgeons are very picky. One wrong case, you're not going to get the surgeon back to you again. Because he is, I completely agree. If I were in his place, I would do the same thing. Because I'm dealing with patients. It's human. Living people. So you got to be very careful. Put yourself in the patient's position and see. If you accept that somebody did something wrong to you, just because it did not work, or somebody did something wrong, no, you will never accept. That's what we money got. You know, after so you have to be very, very careful. So the quality is very, very important. And I had a unique opportunity to set up the quality control. Device industry. So what is the FDA approved? Very important. And the outcome, he said, we have an empowered surgeon. He knows what he's going to do, what he's going to see, what he's going to do. And we have patient who knows what's going to happen before we do. So when the surgeon says, do this, don't work for 5 days, after 5 days, he's going to listen because he knows he will not listen. So we have an empowered surgeon and educated patient, better compliance, better physical outcomes, and in one surgery, no surgery is done by understand the difficulty in the academic community. Surgeon government. Before reimbursement does not happen now, not only here, it doesn't happen in India. We are collecting a lot of data. That is where we look into the computer scientists and the data analysts to give us more information so that we can take it to stakeholders who are insurance people to say that this does have benefits. So there is an upfront cost. The benefits outweigh the upfront. The looking that standardization is very expensive. Is happening the last about 10 years, and I've been a part of the ultimate manufacturing standard collaborative in going back 1, 2, and 3. Because of the medical side, I've been the chair and future for 12 years. Some research interest to ponder. Think about all of this. How you can help. Structured reporting, which is very essential. Great. Even adjusted one color. Now the radiologist is what? A radiologist is like something. B radiologist is like because they're writing a story, writing it in their own way. It's not like so there is an opportunity for people. Now with all this automation coming in, it's like time for us to go and use AI, machine learning and see. These programs can get into the X-ray machines and stuff. So when they see the X-ray, they can say, these are all the highlighted points for radiology. And that can be right now. Any hospital you can have to that the big part. Simulation of human tissue, desktop, understanding that faithful government. Your model is off by 3 meters or 5 meters or strong making a man. But very careful. In some way, we have seen how enhanced visualization help us in doing surgical rehearsal, any topic of guidance, correct or appropriate. Because you are rather than doing this, it doesn't give me 3.5, doesn't have to be. You have your imagine before you go. Have a confidence of it, have a confidence of it, applying for the patient. Things of that. These are some of my challenges. Thank you all for very patient listening and apologize once more for all the delays in starting.